Uterine prolapse, the structure supporting the uterus, upper, round ligament, broad ligament, these are not preventing the prolapse. Middle, transverse cervical ligament or the cardinal ligament, more supportive. Lower, urogenital diaphragm, levator ani and the perineal body. If these muscles or the ligaments stretch or become weak, they are no longer able to support the uterus, causing the prolapse. Uterine prolapse occurs when the uterus sags or slips from its normal position and into the vagina or the birth canal. Risk factors increases with women ages as the estrogen level decreases. Damages to the pelvic muscle and tissues during the pregnancy and childbirth. Women who have had more than one vaginal birth. Postmenopausal women are at the highest risk. Any activity that puts pressure on the pelvic muscles. Other factors that increase your risk for the condition include obesity, chronic coughing, and the chronic constipation. Symptoms: strength inconsistency, feeling on the sitting on a ball, vaginal bleeding, increased discharge, problems with the sexual intercourse, seeing the uterus or the cervix come out of the vagina, pulling or the heavy feelings in the pelvis, constipation, venous congestion can lead to the diabetes ulcer, recurrent bladder infection. Stages: uterine prolapse is described in the stages indicating how far it has descended. Anterior vaginal wall, upper 2/3, sides to cell, most common. Cytourethral lower one-third, urethral, posterior vaginal wall, upper one-third, interior pouch of Douglas hernia. Other pelvic organs such as the bladder or the bubble may also be prolapsed into the vagina. Incomplete uterine prolapse, the uterus is partially displaced into the vagina but not protrude. Complete uterine prolapse, a portion of the uterus protruded from the vaginal opening. The four categories of the uterine prolapse are: Stage 1, replaces the upper half of the vagina. Stage 2, uterus has descended nearly to the opening of the vagina. Stage 3, uterus protrudes out of vagina. Uterus is completely out of vagina in the stage 4. Treatment: non-surgical treatment include losing weight to take stress off of pelvic structure, avoiding the heavy lifting, doing the Kegel exercise, which are pelvic floor exercise that helps strengthen the vaginal muscle, taking estrogen replacement therapy, reduction with the tampon, deceptive ulcer in the case of the genital prolapse, wearing a pessary. A device inserted into the vagina that fits under the cervix and helps push up and stabilize the uterus and cervix. Used to treat the pregnancy with prolapse. Rubber ring pessary used in the uterovaginal prolapse. Surgical treatments include the genital prolapse is the best repaired after the 6 months of the childbirth. Uterine suspension. Surgeon places the uterus back into its original position by reattaching the pelvic ligaments or using the surgical material. Hysterectomy. Surgeon removes the uterus from the body through the abdomen of the vagina. Stroke sling operation. Uterine prolapse in the nulliparous. Posterior called for perineuropathy, prolapsed pouch of the reclusa. Further kills operation with a tubal ligation. Multipara with a second degree uterovaginal prolapse. The Manchester operation or simply fourth girl operation is a technique used in the gynecology operation. It is an operation for the uterine prolapse. Its purpose is to reduce the cystourethral anterior position to the uterus within the pelvis. Steps of the further kill. Preliminary dilation in the curettage. Amputation of cervix. Strengthening the cervix by suturing cut on the end of the macroankle ligament in front of the cervix. Anterior colpography and the posterior colporneurography. Indication of the Manchester operation in the prolapse. Congenital elongation of cervix. Women of less than 35 years of age. Patient who works childbearing function. Uterine prolapse occurs due to the pelvic floor muscle weakness. Multiparity is the most significant risk factor. Prolapse severity is greater from stage 1 to stage 4. Procedentia, complete prolapse. Symptoms include the pelvic pressure, vaginal bulging, and the urinary bubble dysfunction. Kegel exercise and the pessaries are the first line for the mild prolapse. Surgical options include the vaginal hysterectomy, sacroclepharoplasty, and the uterosacral ligament suspension. Also, this is the surgical option for elderly, non-sexually active women. Hopkins system is used for the prolapse staging. Valsalva maneuver during the pelvic exam helps confirm the prolapse. Obesity, menopause, and the chronic constipation increases the risk.